Hi guys, it's me, Professor D, and welcome back to my YouTube channel. On this video, we're doing another Kahoot, and we're going to be covering antihypertensive medications. This is either part two or part three, I'm not sure, but anyway, you're going to learn, right? You're going to learn about these antihypertensive drugs. Before we get started, as always, I'm going to ask you to please support me and support this channel by liking this video. You're going to love it. Go ahead and give it a thumbs up now so you don't forget. Subscribe to my channel if you have done so already. And be sure to check out my website, nexusnursinginstitute.com. There, you can sign up for a next generation NCLEX review session. If you graduated and you're studying for your boards, you don't want to miss this. In part one, I teach you how to think critically. I teach you about prioritization and delegation, different scenarios that NCLEX may present before you and where your mind is supposed to go. I teach you about different phrases and words that NCLEX will use and automatically what you should be thinking about once you see them. In part two, I go over NCLEX type questions that have been seen on the boards, not the exact question, but that content and the rationales and how you're expected to apply them to the type of questions that you get. Maybe you want to pick my brain about something. You can sign up for a consultation session. You can sign up for a private tutoring session. If you're currently in a nursing program and you are struggling, you have to do really well on your next exam. Check out my audio lessons and see if I have one that matches the topic on your next exam. All of those resources and more can be found on my website, nexusnursinginstitute.com. Almost daily, you can find me covering a variety of nursing topics across my social media platforms. TikTok, I don't know how long we're going to have TikTok for, but TikTok, Instagram, Facebook, right here, YouTube, my handle's the same everywhere, Nexus Nursing. Be sure to check that out. Without any further ado, guys, let's get started. Antihypertensive agents. First question. All right, this drug class is the first line drug that's used to treat essential hypertension. And its action prevents the reabsorption of chloride and sodium. What drug class are we talking about? ACE inhibitors, calcium channel blockers, vasodilators, or thiazide diuretics. I gave you two hints. It's the first drug class that's used to treat essential hypertension, and the action of the drug, it prevents reabsorption of chloride and sodium. What do you guys think? Are you kidding me? How did 52 of you guys choose ACE inhibitors? I believe the 52 of you that chose ACE inhibitors was not on this Kahoot yesterday. No. First line, thiazide diuretics. That is the first line class of drugs that are used to treat essential hypertension. And the other clue I gave you was that it prevents the reabsorption of chloride and sodium. Diuretics makes you urinate. It makes you get rid of the fluid. You got to think about what blood pressure is. High blood pressure. Blood pressure is the forces being exerted against the vessel walls. The more fluid you have, the more force is being exerted, the higher your blood pressure is. So the way the diuretic works, as you get rid of fluid, the pressure goes down. How are you getting rid of fluid? Through urination. What is coming out through the urine? Chloride, sodium. Why is that important? What is one of the things that sodium does? Sodium holds on to fluid. So the more sodium you have, the more fluid you're going to hold on to, the more force it's going to be exerted against the vessel walls, the higher your blood pressure is. But the less sodium you have, the less fluid you're holding on to, the less force against the vessel, the lower your blood pressure. Does that make sense, guys? All right, let's keep going. Question number 2. This type of diuretic belongs to a chemical class of drugs called sulfonamides. Are we talking about loop diuretics? Are we talking about osmotic diuretics? Are we talking about thiazide diuretics? Or are we talking about potassium sparing diuretic? Which one are we talking? This is a class of drugs that is a diuretic, and it also belongs to the family of sulfonamides. What are we talking about here? I'm so happy I'm doing this Kahoot because what is going on here? It's thiazide diuretics, guys. This is important. Like, this is a famous nursing question. You have to know this. It belongs to the sulfonamide family. So anybody that's taking a thiazide diuretic, it is contraindicated if they are allergic to thiazides or sulfonamides. You have to know that it comes from the sulfonamide family, okay? Now let's look at the other options. Loop diuretics. Loop diuretics such as Lasix makes you lose potassium, right? Osmotic diuretics, those are the type of diuretics. Remember osmotics? I talked to you about that yesterday. It has that pulling force. These are great drugs we give for patients with increased intracranial pressure. And then potassium sparing diuretics, that S in sparing, I want you to think of spironolactone. It makes you what? Hold on to potassium. Why am I talking about potassium? Why does it make a difference if you're losing potassium, holding on potassium? Because potassium has a very narrow therapeutic range, 3.5 to 5. Anything outside of that, that can cause cardiac dysrhythmia. So you better know the difference between a loop diuretic that makes you lose potassium and a potassium sparing diuretic, that S, that makes you hold on to potassium. You got to know the difference between those two. You have to know that osmotic diuretics are used to treat increased intracranial pressure to get rid of that fluid. And you need to know that thiazide diuretics, again, guys, first class of drugs we're going to give for essential hypertension, and they belong to the family of sulfonamides, so they cannot be given if the patient is allergic to thiazides or sulfonamides. Select all that applies. Thiazide diuretics are contraindicated or should be used with caution in patients with which type of disorders? Select all that applies. Here are your options: liver disease, kidney disease, lupus, diabetes, pregnancy, lactation. If your patient is ordered to get a thiazide diuretic, you are going to withhold that med and call the healthcare provider for clarification if they have which disorder. Select all that apply. Again, liver disease, kidney disease, lupus, diabetes, pregnancy, lactation. Code to get in is 266-7653. Can you guys type that on the live for me, please, for the latecomers? Thank you. 266-7653. That's the code to get in the Kahoot. All right, let's talk about this. All of them, guys. All of them. Let me explain to you why. The first two, liver disease and kidney disease. Guess what? Across the board, when it comes to medications, when it comes to pharmacology, it does not matter what the medication is. It doesn't matter what the drug class is. If the patient has a liver dysfunction or kidney dysfunction, you are going to, at the minimum, give this medication with caution. Why? I want you to think about it, guys. First of all, let's talk about the liver. The liver is responsible for metabolizing these drugs. So if your liver's not working and you're taking the drug, what do you think is going to happen? It's not going to be metabolized the way it's supposed to. The kidney is responsible for excreting the drug. If your kidney's not working, you're not going to be excreting that drug the way you're supposed to. What do you think is going to happen? The patient can have a toxic level of said drug. Duh, right? So liver and kidney disease across the board, doesn't matter drug or class. If the patient's got one of those or both of those, you're at the minimum going to administer with caution. Lupus. Let's talk about lupus. So here's the thing, guys. With lupus, this drug, thiazide diuretics, we love thiazide diuretics. However, it messes with the glomerular filtration of the kidneys. Okay, Professor D, why do we care about that? I'm so glad you asked. Let me tell you why. If you know anything about lupus, you know that one of the biggest risk factors for that patient that has lupus is what? Kidney failure. Kidney failure. After heart disease, the second cause of death in patients with lupus is kidney failure. Okay, that's how bad it is. So why in the world would we give a medication that messes with the glomerular filtration to someone who's already at risk for kidney failure, right? So if that patient has lupus, are you going to give this drug? No. You're going to withhold it and call the healthcare provider and say, hey, I know you want me to give this drug, but are you sure this patient's got lupus? There are other drugs on the market. If that healthcare provider says give it anyway, say, no, I'm not losing my license. You come give it yourself. Let me tell you something. When you know your stuff, you can be very bold talking to the healthcare providers when your license is on the risk. That's not good English. When your license is on, no, when your license is on the line. That's what I meant to say. You don't play with your license, okay? Next, diabetes. Here's why. As much as we love thiazide diuretics, unfortunately, one of the adverse effects is that it increases the glucose levels. Now, that would be okay for someone who's not diabetic because you know your glucose level can increase slightly. But if you are diabetic, that's an issue, right? So you're going to call the healthcare provider and say, hey, did you know this patient's a diabetic? Next, pregnancy and lactation completely contraindicate. If you're pregnant or you're breastfeeding, you cannot take this med because it does travel through the breast milk. Okay? All right, let's keep going. True or false? Thiazide diuretics cause the urine to be slightly alkalinized. Is this true or is this false? What do you guys think? Diva says, are you still going to do these TikToks when TikTok gets banned? You know what, Diva? I did. I thought about this and I am. I'm just going to continue it on YouTube. Yes, I'll be on YouTube doing it. Okay, so let's talk about this. Thiazide diuretics causes the urine to be slightly alkalinized. True. True. Your urine is supposed to be acidic. And that acidic environment is great because bacteria, it's not favorable to bacteria. Bacteria doesn't like to grow in acidic environments, number one. And number two, an acidic environment keeps the bacteria from sticking to the inner lining of the bladder. Your bladder, by the way, is supposed to be a sterile environment. There should not be bacteria. But if there is bacteria, at least if that urine is acidic, it doesn't stick to the lining, so it doesn't have a chance to multiply because as soon as you urinate, it's flushed out of the bladder, right? Now, if it's slightly alkalinized, which is more favorable to the growth of pathogens, it increases the patient's risk of what? What do you guys think this patient would be at risk for when they take a thiazide diuretic, knowing that it causes the urine to be slightly alkalinized? Thank you, UTI. Very good. Very good. Select all that applies. You would hold the drug and question the order for a thiazide diuretic if your patient had which conditions. There are lots of contraindications you guys have to know about thiazide diuretics as much as we love them. So what condition would you hold this drug and call the healthcare provider? Here are your options: gout, hyperparathyroidism, hypotension, hypokalemia, bipolar disorder, hypertension. We already know about liver dysfunction and kidney dysfunction and diabetes, pregnancy, breastfeeding. Yep, we know that, but there are more that you absolutely need to know. What condition would we hold the drug and place a call to the healthcare provider if our patient had this? Select all that applies. What do you guys think? This is interesting. Let's talk about it. So yes on gout. Let's talk about gout. As much as we love thiazide diuretics, one of the things it also does is it decreases the excretion of uric acid. What does that mean? That means uric acid can build up. Do you think that's a good idea for someone who already has gout? Absolutely not. That's going to make their condition even worse, right? So yeah, if we're ordered to give a thiazide diuretic to a patient and we look at the patient's medical history and we see they have gout, are we going to give that drug? No, we're going to call the healthcare provider. Remember, you are the eyes and ears for that healthcare provider. You cannot stand before the board of nursing and say, oh, well, it was ordered by the healthcare provider. Nobody's trying to hear that. You are the person that administered that drug. Hyperparathyroidism, true. Why? I want you to think about it, okay? And this is why it's so important that you guys know your pathophysiology. So the patient's got a thiazide diuretic. They're urinating all over the place. That's what diuretics do. It makes you urinate, right? Okay, cool. What's coming out in the urine? The electrolytes, including what? Calcium. Actually, thiazide. Yes, they're urinating, but the calcium they actually hold on to. So I'm lying. Calcium they hold on to So the patient's urinating, they're holding on to their calcium, but they've got hyperparathyroidism. I want you to think about it. Remember the teaching where I taught you guys about hyperparathyroidism? By the way, you touch right here. This is your thyroid gland, and you got those four little dots. Those are your parathyroid glands, right? So your parathyroid glands are responsible for what? Calcium. Follow me. Patients taking a thiazide diuretic, they're getting rid of electrolytes, but they're holding on to their calcium. They're not getting rid of calcium as much as they are, like sodium or chloride. They're pretty much holding on to their calcium. Do you think that's a good idea for a patient that already has hyperparathyroidism? Remember, when you're thinking of parathyroid, you're going to think about calcium in the blood. If you have hyperparathyroidism, you have a lot of calcium in the blood. Just like if you have hypoparathyroidism, you have less calcium in the blood. So if you have hyperparathyroidism, which means you got a lot of calcium in the blood, do you think it'd be a good idea for a patient to take a thiazide diuretic that makes them hold on to even more calcium? No, absolutely not. By the way, guys, where do we want calcium to be? In the bones. Calcium is what makes the bones strong. We want in the bones, not the blood, right? So we don't want to make that condition worse. Does that make sense? Okay, good. All right, next, hypotension. Why would we withhold the drug and call the healthcare provider if the patient was hypotensive? Well, we're giving a thiazide diuretic to bring down the blood pressure because we know the more you urinate, the more fluid you get rid of. The more fluid you get rid of, the less pressure against the vessels. The less pressure against the vessels, the lower your blood pressure. So this patient's blood pressure is already low, and you think it's a good idea to go ahead and give them a diuretic that's going to make the blood pressure go even lower? Are you trying to throw them into a hypotensive crisis? Absolutely not. We want to keep our license. So we're not going to give that. What about our patient with hypokalemia? Why hypokalemia? Again, this drug makes you urinate and you're losing electrolytes in your urine. Electrolytes such as what? Sodium, chloride, potassium. Yeah. Potassium has a very narrow therapeutic range, 3.5 to 5. That is it. Anything outside of that range, patients at risk for cardiac dysrhythmias, other issues, but one of the most lethal things we're concerned about is hypokalemia. So you're not going to give a thiazide diuretic to a patient because thiazide diuretics already put the patients at risk for hypokalemia. So you absolutely are not going to give this drug. If you look at the lab results, you're right about to give the drug and you look at the labs and you see that patient labs is already less than 3.5. You're not going to give this drug. You're going to withhold it and call the healthcare provider. Last, bipolar disorder. You guys follow me on the live? Okay, bipolar disorder. Why would we not give thiazide diuretics to bipolar disorder? Can you guys tell me which electrolyte you should automatically be thinking about when you see bipolar disorder? Which electrolyte are we concerned about? Quickly. Come on, guys. Thank you. Sodium. You guys need to know this, okay? So, lithium has a very narrow therapeutic range. If a patient's got bipolar disorder, you expect that patient to be on lithium, right? What's the connection, Professor D? Great. I'm so happy you asked. Let me explain to you. Patients taking a thiazide diuretic, they're getting rid of all this urine. What's coming out in the urine? Again, chloride, potassium, and what? Sodium. You want to know the connection between sodium and lithium? If the patient's sodium is too low, that can throw the patient in lithium toxicity. And if their sodium is too high, the patient can get a subtherapeutic level, right? So you better be looking at that sodium range, and it better be between 135 to 145. That is a narrow therapeutic range. If the patient's sodium is less than 135, patient can have lithium toxicity, and then you're going to have a whole other set of problems on your hands. We don't want that. And that can very well happen if the patient's taking a thiazide diuretic. Okay. And last, hypertension, that was not an answer because if the patient's hypertensive, that's why we're giving thiazide diuretic. We're trying to, get that blood pressure down. Now, don't get me wrong. Thiazide diuretics are not only given for hypertension because we also give it, for heart failure and other conditions, but we're talking about blood pressure now. So that's why I keep referring to blood pressure, but that's not the only reason that we would give a thiazide diuretic. So anyway, if the patient is hypertensive, their blood pressure is high, that's not a contraindication to give a thiazide diuretic. That's actually a reason we would give a thiazide diuretic, because we want to bring that blood pressure back down. True or false? Any patient that's taking digoxin and a thiazide diuretic should be monitored closely for dig toxicity. Is this true or is this false? If your patient that's taking a thiazide diuretic is also on digoxin, you have to monitor them for digoxin toxicity. Is this true or is this false? Very good. It's true. It's true. When it comes to digoxin, which electrolyte are we concerned about when it comes to digoxin and thiazide diuretic? What electrolyte are we going to be concerned about, guys? Very good, potassium. There are 13 questions altogether, and we're on number 6. Potassium. If the patient is on digoxin and they're also taking a thiazide diuretic, the reason we're concerned is because we understand that hypokalemia can cause the patient to go into dig toxicity. And guess what? If you're taking a thiazide diuretic, you're urinating all over the place, you're losing potassium all over the place, right? There's a high chance that your potassium can be low that can cause you to go into dig toxicity. It's like a domino effect. That's why we're concerned when it comes to digoxin and thiazide, because we understand that an adverse effect of thiazide is hypokalemia, and hypokalemia can cause digoxin toxicity. True or false? Aside from enalapril, all of the ACE inhibitors are administered orally. Is this true or is this false? Besides enalapril, all of the ACE inhibitors are given PO, by mouth, orally. True or false? It's true. Now, if I said all of the ACE inhibitors are administered orally, that would be false, right? I told you guys to stay away from all. I told you stay away from things that are inclusive, but all inclusive. But this question really isn't all inclusive, because I said aside from. Guys, stop trying to be robots. Think critically. Let me tell you guys something. Aside from enalapril, all of the ACE inhibitors are administered orally. That is very true. So let me say this to you guys. Like captopril, it is given, can be given sublingually. That's very seldomly that captopril is given sublingually. But I'm telling you right now, if it's given sublingually, guess what? That is called, it's known as like off-label or off-brand use. What does that mean? That means that it works, it does what it's supposed to do, but it hasn't been approved by the FDA. What does that mean for you, the nurse? That means that if you were to give that captopril sublingually, because in real life it happens, you know, the doctor will order it because it does the job, but it hasn't been approved to do the job by the FDA. And if you go ahead and you administer a drug that is off-brand or off-label, it hasn't been approved by the FDA, even though it works, it hasn't been approved. You give that drug and something happens, 1 out of 10 million chance of something happening to that patient, you're losing your license. Because at the end of the day, you consult a pharmacist, you consult your drug book, and you will see that you cannot give it sublingually. Be very careful, guys. Do not ever administer a drug that is off-label or off-brand. Just because you see it being done all the time and it works, there's a reason it hasn't been approved by the FDA, because there's that tiny little chance, and you don't want to be the nurse stuck on that tiny little chance. Do you see what I'm saying? So aside from enalapril, that actually it can be given. Besides orally, enalapril can be given IV. It's approved by the FDA, no problem. But I'm telling you right now, captopril, sublingual, don't do it. Don't do it. Something happens to that patient, you're losing your license. Yes, the code to get in is 266-7653. 266-7653. Guys, can you please type that in the live for the latecomers, please? Thank you. Okay, what drug class is known to cause an unrelenting productive cough, photosensitivity, and pancytopenia? Is it loop diuretics, thiazide diuretics, ACE inhibitors, or beta blockers? Which class of antihypertensive agent is known to cause an unrelenting non-productive cough, photosensitivity, and pancytopenia? ACE inhibitors. Very good. Now I have a question for you guys on the live. Which race does this affect the most? In which race do we see the non-productive cough and the pancytopenia the most and the photosensitivity? Yes, in blacks, black patients. Very good. African. Should I say African American or black? Or both of them are okay? I gotta look that up. I don't know. AA descend? Oh, black. Okay. Both works. Okay. You guys know what I mean. Next question. What drug class inhibits vasoconstriction, decreases the heart rate, and decreases cardiac muscle contraction? I can't speak. Here are your options: vasodilators, beta blockers, calcium channel blockers, or potassium sparing diuretics. Again, this class of drug, it inhibits vasoconstriction and it decreases heart rate and cardiac muscle contraction. Very good. Beta blockers. Now, what do the beta blockers end in? What three letters do they end in? Very good. Lol, like propanolol, metoprolol. Very good. Okay. True or false? Excessive sweating, vomiting, diarrhea, and dehydration should be reported immediately in any patient taking a vasodilator. Is this true or is this false? Very good. Shame on the three of you that chose false. Very good. True. First of all, excessive anything is bad, right? Excessive sweating, vomiting, diarrhea, they're losing all these fluids and electrolytes, right? The less fluid, less pressure. Do you think that would be a good idea to give that person who's losing all this fluid, which means the pressure is going down, to go ahead and give them a vasodilator that would cause the pressure to go down even more? That patient's going to be on the ground. Your blood pressure gets low enough, your organs start to shut down, right? So that's where this question's going. Excessive sweating, vomiting, diarrhea, the patient's dehydrated, that lets you know there's not enough fluid in the vessels, not enough fluid in the vessels, not enough pressure against the vessels, not enough blood pressure. All right. Your patient presents with dyspnea, headache, vomiting, ataxia, loss of consciousness, dilated pupils, shallow breathing. They're on the vasodilator. What do you suspect is happening? Would it be dig toxicity? Would it be cyanide toxicity? Would it be lithium toxicity? Or would it be a hypertensive crisis? Your patient that's on a vasodilator is exhibiting dyspnea, headache, vomiting, dizziness, ataxia, loss of consciousness, dilated pupils, and shallow breathing. What do you guys think is happening? Wow. Only 4 people chose the correct answer. Listen, first of all, you guys better know the signs and symptoms of ditch toxicity, okay? Those are not signs and symptoms of ditch toxicity. Patients got ditch toxicity. They'll have like blurred vision, they'll yellow vision. Those are other signs. These are not signs of ditch toxicity. You guys better know the signs of ditch toxicity. The correct answer is cyanide toxicity. Guys, you got to know this. So nitropress, guys, that's a type of vasodilator. Guess what? It's metabolized to cyanide. Did you know that? You need to know that. So this drug, nitropress, that is a vasodilator. When it's metabolized, it's what? Cyanide. Now imagine that type of patient. Something's wrong with the kidney. They're not excreting that cyanide. What do you think happens? It builds up cyanide toxicity, cyanide poisoning. And for you, you better not play. You better know those signs and symptoms of cyanide toxicity. Kim says, yeah, I'm going to fail my NCLEX. No, you're not, Kim. Don't say that. You're learning. Don't say that. And there's power in the tongue. So you better speak positively. You're going to pass your boards. You're going to learn this information. Next question. True or false? Calcium channel blockers should be taken with food. Is this true or is this false? Calcium channel blockers. I love you guys too, Tamara. Thank you. While you guys are thinking of your answer, if you haven't already subscribed to my channel on YouTube, please go do that. Nexus Nursing. Okay, I don't know how long we're going to have TikTok for, but once it's banned, you won't find me there anymore. So go to my YouTube channel, find me, subscribe, start watching those videos. All right, calcium channel blockers. No, that's false. It should not be taken with food. Calcium channel blockers need to be taken on an empty stomach, either 1 hour before meals or 2 hours after meals to increase absorption and effectiveness. You need to know this, okay? All right, one more question. True or false? ACE inhibitors should be taken with ARBs for increased absorption and effectiveness. Is this true or is this false? False. You better never, ever, 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 ever give an ACE inhibitor and an ARB together. You will that patient or darn near do that to them. Okay. These are very, 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 very strong antihypertensive agents. And together they have a synergistic effect. You'll be standing before the board of nursing. Don't do it. They should never be taken together. Jasmine says, okay, I'm logging out. Guys, listen, don't be frustrated. This is where you learn and make mistakes for fun so that when you're taking your test and it's serious, you answer it right. Don't be discouraged. Do not be discouraged. Okay? What do ARB stand for? Angiotensin something blocker 2. What's the R stands? Angiotensin, wait, ARBs, ARBS. Angiotensin renin? Oh my gosh. Thank you, receptor. Not reuptake, receptor. Angiotensin, yeah, thank you. Angiotensin receptor blocker 2. That's your ARBs. I had a brain fart. Sorry about that. All right, let's see how you guys did on this Kahoot.